Etzioni. Yeah.
So she's a biostatistician at Fred Hutch and specializes in mathematical modeling of cancer progression and outcomes. Really, really looking forward to this talk because it's related to one of the hottest topics. And if you guys were at the JAMA talk a few weeks ago, like the editor brought up this like overdiagnosis of breast cancer. So Ruth is going to give us her perspective on this.
Okay, thank you. Thanks. Thank you. Well, thanks for coming. Thanks for inviting me. I haven't spoken here for a very long time. The last time I spoke to this group, you were in you were not actually in this building. So that's how old I am. So I especially said don't spend a lot of time introducing me because I'll kind of introduce myself. I have some sense of what you all do over here. And if we had more time, and we may have some time afterwards, I'd love to hear more about how that's evolving. I'm not sure that you have a sense about what we do, or I'm doing certainly at the Fred Hutchinson. So I thought I'd take a couple of minutes to talk about the Fred Hutch and about particularly the Public Health Sciences Division, which is the biggest division in the Fred Hutchinson. And we have epidemiologists, biostatisticians, and we also have a cancer biology department and a computational biology. And when I tell people about what I do, I've been there for over 20 years, and when I tell people as a biostatistician what I do, I'm kind of squeezing the juice of an orange. And what I mean by that is that here we have an orange, and we can see it, and inside it, there's more stuff, right? So what we spend a lot of our time doing is looking at population trends in cancer incidence and mortality and trying to understand mechanisms and explanations for those trends. And I've been doing this for, I want to say, almost 20 years. And over the last 10 to 15 years, I've been working very closely with a consortium called the Cancer Intervention and Surveillance Modeling Network. And we are statisticians, modelers, medical decision makers, and we're really trying to understand what is contributing to changes in cancer incidence and mortality. And so in the case of breast cancer, for example, with declines in breast cancer mortality, what are the roles of screening versus treatment changes in explaining those mortality declines? And so what we're trying to do is kind of get at the story behind the data. And I know that you are all doing that in a certain sense as well. You're looking at a lot of data on disease and trying to understand how to move it, how to impact it, and why those trends are the way they are. And so I'm going to talk particularly about breast and prostate cancer today and about this hot topic of overdiagnosis. So I know that if you were here a short while ago, well, you heard the editor of JAMA, and I know that you also heard Gil Welch, who's a very prominent and prolific writer on overdiagnosis, also in breast and prostate cancer. And so probably you have a sense of what we're talking about when we talk about overdiagnosis, and maybe even you're looking at that iceberg and kind of figuring out why there's an iceberg on my title slide, right? Because what we're talking about is we're talking about a disease that has a latent component. And so when we now screen for that disease, we're now getting a window, and we're able to detect some of those latent cancers. We're going below the surface of the iceberg. And what I really want to talk about today is the numbers. That there is overdiagnosis is probably not in question, but how much overdiagnosis is there? And why is this so critical? It's because when you screen for cancer, you're screening a healthy population, and you are only able to affect the cancer fate of the subset of that population that will have a potentially fatal cancer. But you may affect the health of many more people by intervening if you cause harm. And overdiagnosis is currently and justifiably considered to be perhaps the worst potential harm of cancer screening, and therefore it's critically important as we evolve our cancer screening policies, which is happening all the time, to get a good handle on the numbers. And so that's really going to be my focus today. I want to encourage you to ask questions during the talk. I was very tempted to ask you guys a lot of questions right now just to get started, but I thought I would break the ice. Either ask questions, or if you're not following something, just scrunch up your face and look really puzzled, and then I'll know that I'm not explaining it very well, okay? Let's talk about the burden of breast and prostate cancer in the US. So these are trends. This is an annual review of cancer statistics published each year in CA, Cancer Journal. These trends, in case you can't see, begin in 1975 and go through 2009, and we're looking at male cancers and female cancers. So the first thing we see is the relative burden of breast and prostate cancer. These are invasive cancers. Prostate cancer screening came into the population in the late 1980s and the early 1990s, and you can see that dramatic change in incidence of prostate cancer. And the breast cancer trends these are invasive cases, and what we'll see later is the invasive plus in situ cases, with screening beginning in the 80s, and I'll show you that in more detail. And American Cancer Society is estimating about 233,000 new cases of each in 2014, and roughly 29,000 to 30,000 deaths in each case. So even if you didn't come to those last two talks that I mentioned, I'm sure that you have seen something about overdiagnosis in the mainstream media. And these three articles are actually all from the New York Times. And we have just been barraged with articles about overdiagnosis, most recently in breast cancer. Where are these coming from? Well, they're coming from publications in the literature. And this was probably one of the most prominent publications in the last few years by Blyer and Welch, estimating that about 31% of all breast cancers diagnosed in 2008 had been overdiagnosed. And we'll explain exactly what that means in a moment. And this is really causing a lot of consternation on the policy front. And so this is a recent article in the New England Journal. The Swiss Medical Board, which sounds very much like an authority, it's not an authoritative board, but it's a board, and it has got a perspective in the New England Journal, called for a moratorium on any new screening mammography programs in Switzerland and a time limit on those that currently exist. And the American Cancer Society and the U.S. Preventive Services Task Force are right now working on their updated recommendations. And I'll share some of my thoughts on that process because I'm working with the American Cancer Society on their recommendations and trying to pull the evidence together and how hard it is to do it for overdiagnosis. Now, overdiagnosis in prostate cancer is not talked about as much these days, but it has a history, and it was a great topic of conversation and consternation 10 years ago. This actually is an article from 1999 looking at the increase in incidence in prostate cancer and questioning whether that was real early detection or just overdiagnosis. And again, another article that kind of has provided fuel for the fire, suggesting that this really is a huge problem in prostate cancer, is this article that looked at the excess incidence, the excess cases of prostate cancer after the advent of screening. So here, these are excess cases. The zero so it's relative to the pre-PSA screening era in different age groups, and kind of adding up those excess cases up to 2005. Remember, screening came in the late 80s, early 90s. Since 1986, an estimated additional 1.3 million men being diagnosed with prostate cancer that would not have been diagnosed. Extra diagnoses, overdiagnoses, would not have been diagnosed in the absence of screening. And so this was all kind of a few years ago. This was an article actually published by, oh, I'm using the wrong thing. I'm using the right thing. How do I? An article published by actually one of the developers of the PSA test, titled The Great Prostate Mistake. And this actually cited a very influential publication from the European randomized trial of prostate cancer screening that not only looked at the amount of excess cases in the screened arm relative to the control arm, but actually calculated a trade-off measure where they looked at tried to get a sense of how many overdiagnoses, how much harm are we getting relative to lives saved, and calculating both of those from the clinical trial being, of course, the gold standard for screening benefit, with observational studies potentially subject to, bias in screening particularly, and of course in everything, but with really clinical trials being the gold standard for benefit of screening, also using the clinical trial to get at overdiagnosis and to get this trade-off. And they calculated that 48 men would be overdiagnosed for every life saved. And this was cited in this article. And very much moving policy, 2012. I'm sure you have read, again, there was a lot of media about this. The U.S. Preventive Services Task Force, the authoritative policy panel on screening in the U.S., recommending U.S. Preventive Services Task Force recommending against prostate cancer screening. Blanket recommendation, do not do in 2012. So this is our backdrop, and this is just a huge topic of concern and controversy. And part of it comes from the fact that we don't really have a good sense of how bad this problem is. There's a huge range in estimates of overdiagnosis in breast and also in prostate cancer. And so what we'll do today is just first, I'll make sure that we're talking about the same thing when we talk about overdiagnosis, and try to understand why there's such a range, and then really get into a little bit of the methods and kind of understand the role of the methods in this wide range. Because methods, and the vast majority of papers on overdiagnosis have been published in the clinical literature, and methods often kind of are second order. And the issue of methods and the role of methods in the variability of estimates is something that we've been thinking about over the last year or two. Okay, so the problem of overdiagnosis, a lot of cancer lies beneath the surface. You'll have a point of disease onset. Disease will be latent. This is the whole justification for using, for trying to screen for cancer, to try to detect disease while it is latent. At some point, disease will be symptomatically or clinically diagnosed in the absence of screening. And prior to that point, and that point may be many years from onset, it may be never in a person's natural lifetime, but in that latent period, if the cancer is diagnosed by screening, this is a potential overdiagnosis. So when is it an overdiagnosis? It's an overdiagnosis if it's detected by screening during the latent period, but death from other causes is then the next event, that the person never reaches the point of symptomatic or clinical diagnosis in their lifetime. So when does it happen? Just to introduce the jargon of screening, it happens when other cause death occurs between screen detection and the point at which disease would have eventually been diagnosed. And that interval we refer to as the lead time. And you can imagine that if you have a very slow-growing cancer that would take a long time to reach the point of clinical diagnosis or symptoms, you have a much greater chance of other cause death happening in that interval. Or if you are at high risk of other cause death due to advanced age or comorbidity, then you have a higher chance of dying of other causes in that interval. So overdiagnosis is a cancer. It's not a false positive. It's a real cancer. And the chance that you will be that a case will be overdiagnosed depends on case characteristics, age and comorbidity, influencing the chance of other cause death, and disease characteristics, also screening test characteristics, which both influence the lead time. And so overdiagnosis occurs, you could say, when the time from screen detection to other cause death is less than the lead time. And for those of you that deal with survival analysis, so you can think of overdiagnosis as kind of a competing risks process, where you have two risks, the risk of clinical diagnosis and the risk of other cause death, and they compete with each other. Any questions? Okay. Okay, and this is where the squeezing the orange comes in, because we can see the orange, we can't see what's inside it. We can observe features of population incidence. We actually can't observe overdiagnosis. Once this case is screen detected, typically the case is treated, and we cannot ever observe what would have happened. And so we can't know whether the person would have died before symptoms would have occurred. There are two ways that people learn about overdiagnosis. The first is by looking at incidence. If we have a lot of excess incidence in the presence of screening, we worry about overdiagnosis. And the second way is to get into learning about the disease progression or natural history, trying to understand that lead time process and what generates it. The key lesson of today is that the approach really matters. Here, just a sampling of studies, some very high profile from the breast cancer literature. The blue ones are excess incidence studies, and the red ones are lead time, or what I'll call modeling studies, which get into modeling of the latent disease natural history. And there are differences besides approach. So first of all, and I'll get back to these, not all of them include in situ cases in breast cancer. So in situ cases are considered to not be invasive. The cancer has not invaded the ducts, but there are cancer cells, right? And the incidence of in situ cases has greatly increased under screening. And not all of them, some of them just ignore the in situ cases, only focus on the invasive cases. And overdiagnosis is also very often expressed as a ratio. Sometimes it's just absolute number of cases, like if you want to give a sense of the burden of overdiagnosis in the population, as in that Welch and Albertson paper, maybe you'll give an absolute number. But it's typically represented as a ratio. And there are many different denominators, at least 5 different potential denominators for an overdiagnosis estimate. And so that also can explain some difference across studies. But you can just see when you group the studies by approach, there really is an order of magnitude difference. So what I want to do in the next part of the talk is talk about each of these approaches, right? What is the excess incidence approach? And show you some studies and kind of help you think about some of the issues in getting estimates with this kind of approach. So that when you eventually read a newspaper article or or a journal article about overdiagnosis, what I hope is the first thing you'll ask yourself is, what approach did they use? And then you'll be able to say, okay, they used this approach, but then did they think about this point? Did they think about that point? And this is kind of what I'm going to try to give you a flavor for in the next few slides. And then we'll go back then, once we've finished with the excess incidence approach, and we'll then go to the modeling approach, and I'll show you some examples of that. Yeah?
Can I just ask more questions?
Please.
Because in your framework now you say that the early lesion will either lead to death from another cause or clinical diagnosis. But in some hypotheses, it's stated that these early lesions may disappear, so you never would
Right.
be
So
clinically diagnosed.
yes.
So does that framework influence the modeling?
Absolutely, it should, right?
Yeah.
So I'm going to talk about that.
Okay.
Very much going to talk about that. So that's what I was kind of alluding to that. So the question is that, you know, I keep talking about, well, there's a clinical diagnosis, and we have this competing risks process, but maybe there isn't a clinical diagnosis. Maybe the cancer will go away. So I kind of think of that, it's not exactly, but it's when I said it could be a very long time, could be really infinite, right? So, okay. Any other questions? All right. So the excess incidence approach. I'm going to throw you, these are 3 schematics. They really are schematics. I haven't generated them from any data. They're actually based on, the reference will come up. They're based on a 1992 paper by Foyer and Wynn in the American Journal of Epidemiology, thinking about this in breast cancer. And what they do, and what I do here, is I illustrate what might happen if we introduce a screening test into a population in which the background incidence is flat. And each year, the screening test, as it's introduced, detects a certain number of cases. And these are the pluses. In the first year, the screening test, in this case, detects 30 cases. In fact, it's the same in the first two examples. 30 cases in the first year, plus 20 cases in the second year, 10 cases in the third year. Now, there's no overdiagnosis in these first 2 graphs. And so what happens is that the pluses in any given year are then, we're pulling cases from later in time. So when we get to later in time, those cases are no longer there. And the difference, so we have a kind of a pattern of excesses and deficits. And the deficits follow the excesses by the lead time. So if the lead time is 1 year, then the plus 30, those 30 cases are no longer there 1 year later. And so there's a minus 30. And then the plus 20, 1 year later, minus 20. And then plus 10, the screen-detected incidence stabilizes, and eventually the minuses also stabilize. And because there's no overdiagnosis, we return to the background incidence. And the difference between the first and the first and the second, is that the interval between the excesses and the deficits. Here it's 1 year, here it's 2 years. And you can see it takes longer for the deficits to arise in the second case. So we get a different pattern of incidence. We get more of a bump in incidence. And the third graph here adds some overdiagnoses to the pluses, but it keeps the minuses the same. So the minuses are now less than the pluses. So we get even more of an incidence peak, and we don't actually return to the background trend in the end. Okay? But what we notice is that even when we don't have overdiagnosis, we get an excess incidence in the beginning. And so therefore, this brings me to the first of 3 key points. The first is the timing. We have to wait. We need a certain amount of time to wait before we can trust the excess incidence to reflect the overdiagnosis. We need to know what our counterfactual incidence, what our background incidence would be in the absence of screening, which we don't always know in a population setting. And we need to recognize that the denominator matters. I mentioned this before. Here, overdiagnosis is 23% among the screen-detected cases, 9/39, 6/26. But the excess incidence at the end is only 3% higher than it would have been in the absence of screening. And a very common measure, I like to measure overdiagnosis as the fraction of screen-detected cases. I think that's the most relevant denominator. But you often don't know in a population setting which cases are screen-detected and which are not. And very often overdiagnosis will be expressed as relative to the incidence that would have been expected in the absence of screening. And you can get very, very different results depending on the denominator. Okay. How long do you have to wait? The timing issue. This is the one simulation study I've seen on this. And in the simulation study, they have a population with incidence based on UK incidence. And then they impose a 2-yearly screening program running for 20 years. And they have no overdiagnosis. So they simulate the incidence, and they have a screening program. They have no other cause death, basically. They bring people forward. Everyone who's diagnosed by screening would have been diagnosed later clinically. How much later? Based on their assumptions, up to 10 years later. These numbers are among cases who would have been detected in 1 year, how many are brought forward by screening? Among cases that would have been detected in 10 years, how many are brought forward by screening in the current year? So up to 10 years. And what they find is that you have to go, the screening program goes for 20 years and then stops, and they still have to wait till 30 years for the excess incidence to be almost zero. So you have to wait a certain amount of time. And this is a certain design. They stopped screening everyone. It's not a population where everyone started and then stabilized. This kind of simulation has not actually been done, as far as I know, beyond this paper. So I think there's a lot of room to do work to try to understand how to get this right. Now, this is the Blyer and Welch paper, the influential paper that I showed you. And they actually waited a long time. So this is mammography coming in, 1988, 1992, in the 80s, okay? And they waited until 2008. So they waited a good, 20 plus years. And what they've show in their paper is they show early stage cancers in situ and localized. And then they show also late stage cancers. And so this is the incidence under screening, right? And we want to get the excess incidence. So the excess incidence, we need kind of a counterfactual. What would the background incidence have been in the absence of screening? And they have to estimate that over many years. So how do they estimate it? They say, in women under 40, there wasn't much screening going on in these years. Screening really began over 40. So let's look at the increasing trend in incidence in women under 40 and take the annual change and use that for women over 40. And that's the trend. And this is the resulting excess, which is rather large. And it turns out to be 31% of all cases detected in 2008. So they definitely get the timing thing. They probably get the, can't say for sure, they probably get the timing thing right. But what about that counterfactual incidence? So this is a little investigation that I did where I looked at incidence for younger versus older cases. Because breast cancer is a hormonally driven cancer, and the hormonal milieu for older women is very different than for younger women. And so I looked for other cancers that might have the same issue, and I looked at testicular cancer. I looked at trends in testicular cancer for younger versus older men. This is younger men. There's no screening going on here. This is younger men, actually. This is older men. Very different for younger trends over time in the absence of screening for younger versus older cases. So I worried about that counterfactual. Well, I wasn't the only one. If you look at the letters in response to this paper, one of the themes of the letters is what's that counterfactual? Here's one that's based on historic data from the Connecticut Tumor Registry. I didn't create this. Some colleagues of ours in CISNET created it. And you can see this is the trend, the extrapolated trend over time. And this is the paper's optimistic, not optimistic, worst case trend over time, which is higher than what I showed you in the previous slide. So, people do worry about that counterfactual, background counterfactual in the paper, and it has to be extrapolated over many years. So if you get the timing right, you may have a problem with having to extrapolate the counterfactual for a long time. Now I'm going to show you, the next study I'm going to show you is one that has a counterfactual, but there's a question about timing. So this is a study that was published in the Annals of Internal Medicine, a Norwegian study. And what you have in each row is you have these different regions of the country, and they're starting screening at different times. So because they're starting screening at different times, for example, the early year, these regions started early, so they have a contemporary counterfactual in those regions that hadn't started yet. In other words, what would have happened, but I've got it during the same time period. And so I can take the difference between screened and not screened in the same time period. And I can also look back historically and look and see whether there were historical differences that I might need to adjust for. And when you put it all into one graph, it kind of looks like this, where this is post-screening here, and this is contemporary incidence, but no screening, and then this is historic differences that can be adjusted for. And they get 15 to 25% overdiagnosed, and this is relative to what would be expected without screening. But if you look at the time after screening started, this first area was 40% of the country. But the rest really have very little time after screening started. So good counterfactual, worry about timing. In addition to counterfactual and timing, other issues with these studies have been identified. And, you know, in order to save time, I'll just tell you about one of them, and that's number 4. And actually, the paper that I just showed you tried to address these issues. The paper that I just showed you, actually, when they calculated the excess incidence, they didn't use the first screening round. They took away the first screening round, which has a lot of excess, right? But again, was that enough? It's not clear. We need more studies to help us understand what enough is. So the point that I want to make here is that when you're comparing a group under screening versus a group that was not screened, in the group that was screened, let's suppose you're looking at incidence and you're looking at diagnosis at age 55. Well, and you want to compare that against without screening. Well, people diagnosed under screening at age 55 would have been diagnosed later without screening. So you have to kind of age the control group to compare it with the screen group. And how much do you age the control group? So people try to do this, and they try to get it right, and it certainly makes a difference. This review article by Politi, as the first author, tried to do these adjustments and found that it made a big difference. Whether it's enough, again, is still not clear. All right, we need to keep going because I have a few more studies to show you, even on excess incidence. Because I've only shown you population studies of excess incidence, and you really want to talk about trials. Why? Because trials are the gold standard. Are trials gold standard for overdiagnosis? So I hope you believe me, based on what I've said so far, that in trials we also have to worry about timing. We have a counterfactual. Trial hopefully will give us a counterfactual. That there's no imbalances going on, right? But if we're going to take the early years of excess incidence, we have the same issue as in the population. And then we also have to, people haven't really worried that much about questions of the lead time, of aging the control group. How do, they don't really do that in trials. And here is a trial this is a trial that gave the 48-to-1. This was the European randomized study of screening for prostate cancer, and they looked over 9 years, screening up in the control group, screening in the screen group, and every few years, and little screening in the control group, close to none in some cases, some contamination. And they looked at the excess incidence. And they found that in the screened arm, there were 82 per 1,000 cases. In the control arm, the incidence was 48 per 1,000 over the 9 years. And the excess was 34 per 1,000. Relative to screen detected, 34 over 58. 58%, almost 60% of the screen detected cases were estimated to have been overdiagnosed, right? More than half. And when they divided that by the deaths prevented over that short time period, they got 48, okay? Per 1,000, deaths prevented per 1,000, absolute difference in mortality curves. Okay, that was a study that only looked at deaths during the screening period. This recent study, actually it's not a recent study, it's an old study that was recently re-reported and got a lot of press. They looked after the screening period. They found an excess, when they looked up to 10 years after the screening period, they found an excess of 106 at 10 years. So I should say about this trial, they screened for 5 years, and then they looked 10 years, up to 10 years later. In the 5 years, both groups were screened. One group had just breast exams, the other groups had breast exam plus mammograms. And then they looked at the difference in incidence over the 5 years, and then they also looked at beyond that time, they kept accumulating the difference in incidence, even though they'd only done this official screening for the first 5 years. And they got 106 extra cases. And over the first 5 years, 484 cases had been detected by screening, either breast exam or mammogram, on the screened arm. So they took 106, even though it was cases up to much later, right? The period of which they ascertained the excess was 15 years. The denominator was over the first 5 years. And they got 106 over 484. If you take that 106, the only difference between the arms was that one group got mammograms and the others didn't, but both groups got breast exams. If you take the women who were detected by mammogram only, in other words, their breast exam was negative, their mammogram was positive, there were 212 of those. And 106 over 212 is 50%. So they actually estimated that half of the mammogram-only cancers were overdiagnosed, which is a very large number. But the number that's most cited is the 22%. So this is the New York Times article on this, citing 1 in 5 cancers found with mammography untreated was not a threat to the woman's health. And the caveat here is that we don't know what happened to those two groups in terms of screening after those first 5 years. So I don't know that they stopped screening or both groups stopped screening. Maybe one did more mammograms. We just don't know. And they have some cumulative incidence curves, but they're not published in the publication. Okay, I'm going to actually just put this up and take it down and just say this is a Swedish study, and this is a situation where they did know what happened after the trial. So they had the screening and non-screening period. They had the screening period, they waited a certain amount of time, and they know what happened afterwards. Pretty much screening stopped in both groups. Or at least, I'm sorry, not that screening stopped. They stopped being invited to screening. And the controls were not really invited to screening. They were invited only right at the end for a couple of years. Once they reached the upper age limit, they weren't invited. Just giving you a sense of a trial is just not just a trial, right? How long was the screening period? How long was the follow-up period? What happened after the screening period? All of these questions need to be addressed. Have the proper adjustments been done? Just because it's a trial doesn't necessarily mean it's a gold standard for overdiagnosis, even though it gives you your counterfactual. So, excess incidence is easy to do, and it's looking at the outside of the orange. It's what you can see. You can see incidence, but there are many, many questions that need to be asked about excess incidence studies, and they give a tremendous range. Even within a single study, if they look at different counterfactuals, as was done in an Australian study, they can get a range. You have to ask many questions, and it's not clear even that we can get the right answer, except under very, very ideal circumstances. And there's more work to be done to understand what we need to do to really get the right answer. Okay, are there questions about the excess incidence approach before I just spend 5 to 10 minutes on the modeling approach? No. Okay. So as you can tell, I have concerns about the excess incidence approach. And I don't only have concerns about the excess incidence approach because I'm a modeler. I am a modeler. I also have concerns about the modeling approach. Okay? So it's not like I'm a modeler, use modeling. I'm not going to tell you that. I'm going to tell you about what people do with modeling, so you have a good understanding of it and can ask the right questions and can see opportunity if you're interested in looking at some of these questions. Okay, two different, so again, we have observed data, observed excess incidence. We want to understand what's the lead time or what's the natural history that's behind that. And there's different ways of doing it. And this is just to remind you that the different patterns of incidence are very informative now about the lead time. We get different lead times, we get different patterns, different levels of overdiagnosis, we get different patterns. But if we want to learn about lead time from incidence, we need to know how much screening has been going on. And often with screening, that's more than just knowing how much screening is going on. We need to know how much follow-up is going on. Are people routinely biopsied if they have a positive screen? What is a positive screen in this population? Okay? So we need to understand screening patterns. So there's more to it when we want to try to extract that information. Now, lead time models have a long history in the statistical literature. I could give a whole talk just on this slide. And not just in cancer, but in HIV. Those of you that have done any work looking at latency period, prediction of the size of the epidemic, a lot of work was done that was the methods were very similar and kind of crossed over from cancer to HIV. And what happens is that when you have a cohort that's being screened and you have those serial screening results, it gives you a lot of information. If I have someone that's been screened, say, negative, 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 positive, then there's a good chance that they became detectable in that last interval. Maybe they became detectable before, but then they would have had a false negative test. So we can kind of, estimate, if we have good enough data, we can actually estimate false negative probabilities and even incidence of onset and this preclinical duration or this latency period, and infer from that lead time. And then once we have the lead time, we can do this competing with other cause death if we have that as well. Yeah.
In this modeling framework, can you distinguish the effects of the parameter for lead time in your model and the parameter for overdiagnosis? Don't
Yeah.
like interfere somehow if they're like two unknowns?
Right. So in the traditional literature, they're only estimating lead time. Okay. The use of those models not to go to overdiagnosis is actually fairly new in cancer anyway, right? So if you just assume that if you have a framework, as in the traditional literature, where you in many cases, it's been extended, but like the basic papers have, say, a parametric form for lead time that has, that is kind of one component, it's not a mixture, right? So you just have a lead time distribution, very often exponential in the cancer literature, right? Then lead time and overdiagnosis are tied together. But you can have models where you have progressive cases, and then you have non-progressive cases, and you have lead time among progressive cases. And then you're kind of separating out. You get a little bit of overdiagnosis from the progressive cases who die within their lead time, but then you have this mixture of non-progressive cases. You have an extra parameter, and you have a mixture. And the question is, how are you going to set it up to actually identify the components of that? And really one of my final slides is this question of this identifiability problem that I think only very few papers in breast and prostate cancer have actually addressed. So I hope that answers it. Okay, this is some work that we did where we used an exponential lead time for prostate, and we said, but we don't know what the background trend is, so we try 3 background trends, and then if we assume a linear background trend, we have 3 different lead times under screening patterns in the population, try to get the lead time out. And we formalized it in a later biometrics paper where we really tried to get at these lead times, but under this exponential distribution, okay? And then we got, a few weeks ago, we got this letter from the Journal of General Internal Medicine from 2 authors, it's 3 authors, yeah, who have written a lot about overdiagnosis, and the premise was these kinds of lead time models should not be used to estimate overdiagnosis because they're typically these single component models, and really there's a mixture. And if you estimate overdiagnosis, if you estimate lead time with a single component distribution, but the true lead time is actually a mixture, right? You're going to get misleading results. Question?
I'm sorry, I'm not following what you mean by a single component.
I'm sorry. Thank you so much for asking. I just mean that so if you have a natural history of cancers and you have some that can be non-progressive, right? They can either just start and stay forever or maybe regress. So you say, well, I have a p fraction of those, right? And those are all going to be overdiagnosed. And then in addition, I have some that will progress, and they just have a distribution. That's the single component. But I might not model it as a mixture. I might just say I have the single component, and those guys that are non-progressive just have long times within that one distribution as opposed to a mixture when I say single component. Okay? Thanks for asking. So they said, you guys can't keep doing this. This is wrong. And we should use excess incidence instead. So we responded. It was really, so we didn't say, well, you guys are wrong, because they're right. I mean, they're right. If you have in a certain sense, right? If you have a mixture, and you say, and you ignore that, maybe, you are certainly oversimplifying. Question is, how bad a job are you doing of estimating overdiagnosis? I'll show you a little experiment that we did. It may not be as bad as you think. But for sure, because one method has limitations, does not necessarily mean you should use another method that has very well-known limitations. Maybe we need to improve these lead time methods. And not all the lead time methods are as simple as I've shown you so far. So the first thing that we did was we took a mixture lead time distribution. We simulated data with a mixture lead time distribution, but estimated it under an exponential distribution. So the lead time, P, is the fraction of fraction progressing. And the mean lead time is 3 years for those that progress. And this is the true fraction overdiagnosed. This is in a population the same age as the 2008 breast cancer cases. And then we estimate it under an exponential distribution, and we get these means, right? Now, how do we use survival analysis, parametric survival analysis, to do the estimation. And then we compete this lead time with the other cause death for this population, which is how we got that overdiagnosis. And we don't do too badly. Okay, so our distribution of lead time is wrong. It is not a mixture, but we don't really care about the lead time. We care about the competition of the lead time with other cause death. And you know, some models are wrong, and a lot of models are useful, and so maybe we haven't been doing as badly as we think. And there's more studies that need to be done. Of course, we'd like to be able to estimate the mixture. I'm going to show you a case where we don't explicitly postulate a mixture. We postulate a more complex natural history, where we have, this is for prostate, slow-growing tumors that are low-grade and higher-grade tumors. And so we have this mixture. And we actually have estimated externally biomarker growth. This is for the slow-growing tumors. Let me use the pointer. This is for the lower-grade tumors in cases, and this is for the high-grade tumors, using a large study of serial PSA growth in a screening setting. And so then what we want to do is we want to try to understand this complicated natural history. Notice I'm not assuming an exponential lead time. I've got a bunch of assumptions in this model. The lead time comes out of this model. Okay? But I need to estimate all of these parameters, the onset of the different risk of onset of these different grades, the risk of progression, the risk of symptoms. And I do it under screening patterns in the US population to match grade-specific and stage-specific incidence. And so black is the observed, and gold is the model. And they're all on the same scale, so you can't, it kind of does dampen differences here. I think, you know, they look smaller than, you know, they're kind of dampened a little. So we match very well, I think, local, regional, but we're a little off here. But the point is that this is done in a maximum likelihood framework. We've estimated those transition parameters. Then we actually can get out a lead time distribution. But more than that, we can get out a simulated population. And then when we take that simulated population with onset and progression and superimpose screening, right, we can actually partition each year incidence into screen detected and clinically detected. And for the screen detected, we know who's overdiagnosed and not, because we've modeled it in a, we've got a simulated population. And when we take our modeled incidence and we partition it into overdiagnosed and not, these are our overdiagnoses, right? But you remember I showed you the paper where the incidence, excess incidence was taken relative to pre-PSA levels. I showed it to you by age. And we actually get from this a lower, considerably lower number of overdiagnoses. Now, why does this to me make sense? Because in the early years of screening, you get this big bump in incidence. But it's not all overdiagnoses. Some of it is legitimate early detections. People have been moved forward. So that's why, see this cutout here, these are not overdiagnoses, right? So you would expect an initial peak in incidence among the non-overdiagnosed as well, which you're able to replicate in this setting. And again, I'm not saying that this is correct, but I'm giving you both of these in the same setting. And they're typically done, they're never done together. Excess incidence and lead time typically aren't done together. Question?
Remind me, why doesn't the excess method take into account that you're measuring cases earlier?
It can't partition. It just takes the excess relative to pre-PSA levels. It can't partition the excess into the ones that are true early detections or the ones that are overdiagnosed. But if you wait long enough, they kind of will that you will get it in the end,
And the
right?
background incidence doesn't change. That's one.
This one also assumes that the background incidence doesn't change, okay? But the thing about modeling, the modeling, is that you can try to estimate the lead time, but you don't have to wait as long. You can do it from the first few years of screening. Again, depends on the data. So you don't need to necessarily extrapolate that the background incidence hasn't changed for many years, right? In this case, we do because to get the lead time, we do because we want to kind of replicate the years of the study. So again, what I'm just suggesting is that, you know, there's just that we can maybe learn more. We can learn more if we go beneath the surface, that we can get another perspective. And when we and others have done modeling of this number needed to detect this trade-off, that was 48, it goes all the way down over the long term to 5. But that's not only fixing the numerator, it's also fixing the denominator. And actually, this going down to 5 over the long term is more a function of the denominator, the lives saved, which will change dramatically over time. So this was the point that I wanted to make about modeling, is that you don't have to necessarily extrapolate for a long time to get your lead time, but you have to estimate your model. And if you want to capture the complexity of this mixture, potential mixture, you may end up not being able to estimate all the parameters. And so I call this the basic non-identifiability problem. If I have this in breast cancer, and this screening program, and I have this incidence of in situ and this incidence of invasive, and I want to have a full model where I allow onset to be either in situ or invasive. And I also want to allow in situs to maybe progress to invasive or not. I may end up not being able to estimate all of the parameters in that model. I kind of did a schematic here. And so what people do when they try to address this is I call it corralling the problem. They say, okay, I can't estimate all of the parameters. What can I fix? What can I assume known? And these two papers have done it in different ways. And I like this paper very much. What they do is they assume that basically the natural history of invasive cases is quite well known. So the duration of invasive until it becomes symptomatic is known. And they assume that sensitivity of screening is known. So they kind of corral the problem by making assumptions that they then justify about other parameters of the problem. And in this one, they assume that everyone starts as in situ. They don't allow a mixture of stage at the start. So they corral the problem, they constrain the problem. But it's very few and far between so far. And I know that the CISNET breast cancer groups are working hard on this with the task force, but it's a difficult problem. Okay, so I think I've said everything on this slide except what I think the real crisis is. So the real crisis, I think, is well, that we have some overdiagnosis is clear. But the real crisis right now, I think, is the dissemination of information about overdiagnosis. And as you can see, it's quite complicated. And the methods make a big difference, but they're either not properly vetted in the clinical literature, so papers are being published that have very questionable methods, and they're certainly cannot be processed by the media. And so whenever I see a newspaper article about overdiagnosis, I sigh, particularly if it's on the front page of the New York Times, because millions of people are going to read this, and it's affecting individual decisions, it's going to affect policies. And I'll just end with two quick vignettes. The first one, I have to say, is this is someone who's really been influential in my thinking recently. Her name is Christy Ashwand, and she's the health columnist for the Washington Post. And I met her in Baltimore at a conference, and she gave a talk, and her talk was why I'm opting out of mammography screening. And in that talk, she cited among the harms, she also talked about benefit, the Canadian study estimate of overdiagnosis. And there's no question that screening is a preference-sensitive decision. We're intervening in a healthy population to save a few, and your preferences are going to come into this, particularly with the downside. But when you're exercising your preferences, I'd like for people to have the right numbers. And the second vignette that I want to tell you about is my experience. on the American Cancer Society Guidelines panel, where we are trying to make guidelines for breast cancer screening recommendation. And we're supposed to do an evidence review. And a typical evidence review might give the whole range of studies of overdiagnosis. But I, after working through all the studies, I gave them all grades for the American Cancer Society, and there's about 3 that I might use. And I feel like the studies really haven't been done. So how are we going to justify the fact that we kind of are now handpicking these studies, and that, you know, what are we going to use to do this guideline and to do it right? It's something that, yeah, actually keeps me up at night. And this is from an article that we published, which kind of summarizes all the questions based on the talk. If you don't, if you need a reference list, that I hope when you read overdiagnosis studies or talk about it, you'll ask. There's a lot that you need to know before you know if you can trust overdiagnosis estimate. I want to thank our support from the CISNET consortium and our group. Roman and Jing are sitting in the middle there, my colleagues, and thank you for your attention. Thank you.
I'm not really delayed, but is there any very pressing questions that?
Oh, of course.
One question and then.
Yeah, sure.
So yeah, so my interpretation of your talk is that overdiagnosis is overdiagnosed, maybe with a factor of 2 or
Yeah.
3 or something like that.
I'm feeling comfortable right now thinking it's very different for in situ and invasive.
Yeah.
I think it has to present. I'm not comfortable with the studies that take out in situ, and I think that the excess incidence studies are inflated for invasive, yes. And overdiagnosis is also oversimplified. It's complicated. Yeah.
But one thing that strikes me, also now there is a lot of discussion was maybe prostate cancer, now it's breast cancer.
Mm-hmm.
But I think that this debate, it makes people question screening for all cancers. So I was wondering, what happens if you apply these methods to colorectal cancer or cervical cancer and put them side by side? Has anyone done that?
So the short answer is no, but I'm very glad that you asked that question. So the question is, why are people questioning screening? And it's very true that screening is kind of in the dog box right now. And certainly the debate about overdiagnosis and the harms is a part of that. But I think that part of the reason that people are questioning screening is also that we have changed the metric that we use for benefit. And it's making it clear that a very small fraction of the population benefits from screening. So if it's what's your denominator. So before, people would take relative benefit from trials. And you know, if a trial gave a 20% reduction in mortality, that was a success. Screening worked. And that kind of was a number that was used to power trials and was a number that was used to kind of consider the benefits of screening. But then people change. And I think it may have been the task force. It may even have been, I'm trying to kind of trace this change. Not so much that relative reduction, but the absolute reduction. If we screen 1,000 people, among the screened people, how many lives would we save? And very much and focus on that. And so then you say, okay, over the period, a 10 to 15 year period, which maybe isn't the right time horizon, you know, we might save 1 life of 1,000 from breast cancer, death, or 15 year, I can't remember the period. And that doesn't sound, so when Christy Ashwandon gave her talk, she said, you know, if I get screened, if I don't get screened for 15 years, you know, there's a 5 in 1,000 chance I'll die of breast cancer. And if I get screened, there's a 4 in 1,000 chance I'll die of breast cancer. That's a 20% reduction, but it doesn't sound like very much. And I think that people kind of just taking the population that's being intervened on as the denominator, I actually think that is even pushing people to reconsider screening more than the overdiagnosis question. So I hope that's helpful. And it's now what's the right denominator? You know, sure, it's 1 per 1,000, but you know, 5 friends that would have died of breast cancer and one of them now doesn't die, that's meaningful, right? So, thanks.